Okay, so today I'm going to be addressing essay prompt 1, which is going to go over the depolarization and muscle contraction within the heart muscle. And I'm also going to talk to you about the conduction systems and how we send signal throughout the heart. Then I'm going to go into detail about some heart failure and how that can affect the way that our heart does work. So, our heart is actually pretty cool. We have something in our heart called pacemaker cells, and pacemaker cells can actually make their own signal be sent throughout the heart without the brain telling us to do so. So, for instance, if you were to take the heart out of a human, it would still be outside of the human because of these pacemaker cells. So, in our heart, we also have some myocardial cells, and these are going to be like our contracting cells, the ones that actually make our heart contract. So in the heart cell, there's actually going to be a concentration gradient of negative to positive. At our rest, the inside of the cell is going to be more negative than the outside of the cell, and it's going to be about negative 90 millivolts. And this occurs because we have a lot more potassium inside the cell and a lot more sodium outside of the cell. So in order to get this cell to become more positive, we have a thing called the sodium-potassium pump. And this sodium-potassium pump is actually going to allow sodium to come in and make this cell less negative. When that cell becomes less negative, it's going to depolarize. So depolarizing, making it less negative because the sodium's coming in. So I'm going to draw a little chart here to try and explain that a little bit better. So right now, we're at that negative 90. We're at resting membrane potential. This heart cell is actually going to receive a signal which is sent from either our SA node, AV node, one of those two. Hopefully you're going to be your SA node and not your AV node, but our heart has a way of making sure that it does contract even if it's not from the SA node first. So we're at this resting membrane potential. Sodium's coming into the cell. It's making it less negative, so it's becoming more positive until we reach this thing called threshold. If we reach threshold, then that depolarization is going to be completely sent, and the cell is going to become more polarized right here until we reach this point right about here. At this point, we're actually going to close those sodium channels and we're going to open up the potassium channels because we want to get that cell back to its resting potential. So sodium channels close, potassium opens, potassium rushes back into the cell. And when that happens, it's called repolarization. I'm just going to abbreviate that for you guys. And sometimes we will have a thing called hyperpolarization, and that's when we go below resting membrane potential. And when we do this, it just allows everything to go back to normal. It'll allow the sodium and potassium to kind of get back to their normal range. And then we'll be able to send that depolarization signal again and hopefully result in a contraction. One thing about the heart cells is this is kind of like a normal cell that you would see whenever it comes to D and repolarization. But in our heart, we have our contractile tissues. It's kind of going to look like this in a way. We're actually going to have a longer period in between these two, and that's actually going to allow calcium to go in and out of the cell. And once that calcium is in the cell, it's going to be responsible for initiating muscle contraction. So, with muscle contraction, we have things called T-tubules. And these T-tubules are actually responsible for allowing that calcium to come in, as well as that voltage signal that was sent through the depolarization to come into the muscle cells. So all of that is going to be sent down into this T-tubule, and this T-tubule is going to sense that signal, and inside that T-tubule we have voltage calcium receptors right here. So I'm going to call them little feet, but these feet pretty much sense that influx of calcium as well as the signal being sent, and they're going to tell the sarcoplasmic reticulum, hey, something's happening, we had a depolarization being sent, we need to release calcium. Reason being we need to release calcium is because calcium is responsible for muscle contraction. If we don't have calcium going into the cells, we're not going to be able to have that contraction occur. So, draw this little figure right here for you guys. There's a thing inside of our cells called actin and myosin. Actin is going to be about right here, and then we have myosin. So whenever these things overlap, we're actually able to have a muscle contraction. But there's something that is causing them to not constantly overlap and cannot bind, and that is actually going to be troponin. So pretend you have your actin right here. Troponin is kind of like a gate, a guard, if you would. That's going to be blocking the binding sites for myosin to grab onto actin. So if myosin cannot grab onto actin, we are not able to have a muscle contraction. So that calcium is actually going to bind to something called troponin C. And when it binds to troponin C, there's a few other parts that shift as well. Troponin C is actually going to change its form, and it's going to move troponin I, which is troponin inhibitory. And then once it moves that, it will then move troponin T, which it's called troponin T because it binds to tropomyosin. And when it shifts to troponin T, the tropomyosin will then shift off of actin, and it will expose it back to this myosin. So think of this myosin as like little hands. It kind of looks like a little hand right here. But essentially, now that it's exposed, this myosin is going to grab onto the actin. And once this myosin grabs onto the actin, it's going to want that muscle contraction to occur. So it's going to pull these little sarcomeres together to cause a contraction. So I'm going to use my fingers to try and help out a little bit. So they're now binded. The myosin and actin are now binded. This myosin is actually going to have an ADP and an inorganic phosphate already on it. So in order for that contraction to occur all the way, it's going to drop off an ADP and a drop off an inorganic phosphate. So now they're fully contracted. They can't go anywhere. So in order for this to restart, we're going to have an ATP come in, bind with this myosin head, and make it drop off and reload. So recocking of the myosin head. That way we're able to have another muscle contraction occur. All of that is actually going to be happening in our heart. And it's able to do so because in our heart, we have things called gap junctions that connect our cardiac tissue. And one thing that's really cool about our cardiac tissue is we have intercalated disc, and those allow for the signal to propagate throughout the heart in a certain rhythm to make sure that the atrium contracts, then the ventricles, all in the right order. So this is the mechanical side, and we know that there's an electrical signal being sent. So one way to think about this is we can look at it through a EKG, which will have a P, Q, or S, and a T wave. But first, I'm going to explain pretty much what the SA node does to the AV node and how it propagates throughout the heart. So this SA node, it's going to have its inherent automaticity. It's going to fire at 60 to 100 beats per minute. And that signal is going to be sent kind of like in a wave form because of those intercalated discs. And that signal is actually going to reach this AV node. We have a thing called AV nodal delay, which is actually pretty cool. This AV node, you see how it's kind of shaped like a bean? Well, it's shaped like that for a reason. It's so that signal can actually start and then stop at a certain point before the ventricles fire. The reason we need this is because, yes, we have passive filling in the ventricles, but there's still some blood in the atrium that we need to get down into our ventricles. So this allows for all that blood to go down. That signal is then going to be sent down the bundle of His into the bundle branches. So once that signal is sent to the bundle branches, we're going to start having the ventricles try to contract, which is going to be depolarization of the ventricles. Then these Purkinje fibers, they wrap around kind of like the entire heart. These fibers are going to wrap around, send that signal, and our heart's going to start to contract bottom up. The reason why we need that to contract bottom up is because we want the blood from the ventricles going out of the aorta or pulmonary arteries to supply blood to the rest of the body. One way you can look at this is through the P wave. We actually have atrial depolarization, and we know that this is occurring because of the SA node, and that the SA node has fired. And a way you can look at this is, this kind of looks like a weird S. So SA node right here. And then that QRS complex is going to represent ventricular depolarization. So the reason I wrote it right here is kind of so you can see it where the heart is at. And we know that this has reached the AV node because this looks like a V and an A, AV right here. And then this is going to be also atrial repolarization. It's just kind of blocked because this depolarization of the ventricles is so large. And then we go into the T wave. That T wave is actually going to be the relaxation of the ventricles. So the repolarization, think of relaxation, they both start with R's. And that's going to allow our heart to kind of go back to normal and wait for that next signal to be sent. And the whole thing's going to start all over again. Our heart's actually pretty cool with the way that it does contract. It doesn't all contract at once, because then how the heck would we get blood out of the heart? Our heart is actually going to contract top down, bottom up. So atrium, ventricles up, which is really cool. And you can think of it as like kind of like a ringing motion, because we want these ventricles to kind of like get smaller and smaller and smaller, so we can overcome the back pressure coming off of our aorta and get the blood out of the heart into the body. So kind of think of it as like you're wringing out a rag. That's the motion of our heart. It just kind of rings in and pushes it out the aorta. So now that's going to lead me into some specific things that could actually happen within your heart that will not allow it to either get blood out or allow blood into the heart. And one of the main things I'm going to talk about is heart failure. And there's actually two parts of heart failure. We can have heart failure during systolic or heart failure during diastole. So systole or diastole. We know that systolic means that our heart is going to be contracting, and diastolic means that that's when our heart is going to be relaxing. So with heart failure, it's going to actually affect our cardiac output. So I'm going to go ahead and write the cardiac output equation on here. So Q equals heart rate times stroke volume. Q is cardiac output. With our stroke volume, there's actually three parts that make it up. We have our preload, our contractility, and our afterload. Boom, bam. So preload is pretty much going to be Frank Sterling's mechanism. So the greater we're able to stretch our ventricles right here, and the bigger that they're able to become, the more blood that we can fill into them. So that's our preload. Contractility is just the way that our heart contracts. So just if it's contracting good, if it's contracting bad, there's a few things that can affect that. And then afterload is actually us trying to overcome this back pressure that's coming from the aorta. When it comes to heart failure, we know that when we're contracting, that's going to be systolic. When our heart's relaxing, it's going to be diastolic. So for HFrEF is actually going to be heart failure due to a reduced ejection fraction. So that means that the amount of blood leaving our ventricles and trying to go to the rest of our body through the aorta is going to be decreased. A few things can actually cause heart failure with a reduced ejection fraction. One of these things can be hypertension. If we're hypertensive, then there's going to be more pressure coming off the aorta, and it's going to be harder to get that blood out of our ventricles. Another one can maybe be aortic stenosis, so hardening of the aorta, and it won't allow blood to flow out like it needs to. Another one could be coronary artery disease. There's a whole lot of things that can affect why we're not able to get the ventricles to get the blood out of the heart and through the aorta to the rest of their body. So with HFrEF, we are going to see that increase in afterload. We're also going to see an increase in preload due to the compensation mechanism of the increase of afterload. So our body, it's not trying to hurt us, but in the long run it does in a way. Reason being is because we're increasing our preload. So we're increasing the way that those sarcomeres can stretch, and they're only going to be able to stretch and go back to normal so many times before they just kapoo and they can't do it anymore. So one of the compensation mechanisms that our heart actually does is we have those sarcomeres. Remember when I was talking about contractility? And it's best if they go in parallel. So if they are like, okay, we need to contract and do more force, we're going to have these go in parallel. That's what it's supposed to do. But with HFrEF, due to the inability to really get the heart out, blood out of the heart, it starts to stack them in series. And when it stacks them in series, it's going to cause ventricular hypertrophy, which is not really a good thing because it's making our ventricles a lot bigger, but it's also a lot harder for them to contract and get the blood out of the aorta. So that's going to lead me into heart failure with a preserved ejection fraction. So this is whenever our heart is trying to relax. One thing that we do see is left ventricle hypertrophy. This can lead to a decrease in our preload. So all that this is saying is that there is a problem with filling the heart. If we have a decrease in preload, that means that we're not able to fill the heart the way that it needs. And when we're not able to fill the heart, we're not able to fill the ventricles, and we're going to have a preserved ejection fraction, because we're not getting the proper amount of blood out of the heart anymore. So if we are suspected that our patient may have heart failure, there's actually a way that we can test for this, and it's going to be called a nuclear stress test. So with that nuclear stress test, our patient... So with the nuclear stress test, pretend this is our patient. Body, arms. Okay. We're actually going to inject a dye, and this is going to be a nuclear dye, so radioactive isotope, and it's going to circulate throughout the body, and it's going to circulate in the heart, and just keep going back and forth. So this radioactive isotope is just circulating throughout our patient's body. The term stress and the nuclear stress test is going to be putting this patient through either an exercise or walking on a treadmill. What this is going to do is stress the heart, so increase the heart rate. That's the goal, because we want more blood to be going through the heart to see if there's a blockage in our coronary arteries. Now, if there's a blockage in our coronary arteries, we may see something that looks like this, like someone took a bite out of our donut, which this is showing poor perfusion throughout the arteries because there's a little dead space. So this radioactive isotope, it will not flow through areas that are either congested or won't allow for proper perfusion of the heart. So whenever that radioactive isotope is in the body, they stress the person's heart. Once they're done stressing the heart, they take images, and that's where we're able to see if blood is actually being perfused throughout the heart. And this is really good to test for HFrEF, because we're testing in systolic, so whenever the heart is contracting. We can also use this for HFpEF, but it's a little bit harder to see whenever the heart is relaxing because we're trying to check the perfusion of the heart. There are also some patients who cannot perform exercise, say that they have asthma or they're really obese and exercise is actually really uncomfortable for them. We can actually still put them through a stress test, but instead of using exercise as a modality for stress, we can use some pharmaceuticals, which will either increase the heart rate or it will decrease the heart rate, causing vasodilation. What these are going to do, say for instance, we have one, and it's called dobutamine, which is a pretty common one that you might use whenever you're pharmaceutically stress testing someone. What this is going to do, it's actually going to increase the heart rate without exercise. So this is going to be a good one for patients who can withstand an increase in heart rate, but who cannot exercise. This is also done with nuclear imaging or an echocardiogram. We also have another one, and that's adenosine. And what this one does is it's going to decrease the heart rate or cause no change in the heart rate. But what it's going to do is it's going to cause their coronary arteries to vasodilate. So say this is their normal resting arteries. What it does is it causes them to allow more blood to flow through them. So with an echocardiogram, echo meaning sound, we're actually using sound waves to detect if there are any blockages to allow us to see what's actually going on in the heart. Okay. So we actually have a transducer head. So say this is our patient again. And this transducer head is going to be pretty much put here or here, just around the heart. And that's going to allow us to send those sound waves and get an image reflected back from those sound waves. In the image, sometimes you might see a white image, and that's going to be the reflection of the sound waves coming back at you. And that white image is pretty much going to be the tissue in the heart. It's going to be hitting that and reflecting back. And whenever we're using an echocardiogram, we're pretty much checking for heart motion. So this is looking at the fluid movement throughout the heart to see if it's flowing in the proper ways that it's supposed to. Okay, so we have a patient who has recently suffered from a myocardial infarction, aka a heart attack, and they are now put on a diuretic, and they also have an emergency vasodilator, and we want to see how their exercise tolerance may be different now that they're on these drugs, but I think it's important for you to actually understand what occurs normally whenever we do exercise. So this is our cardiac output equation: cardiac output, heart rate, stroke volume. So when, just by experience or just by walking up a flight of stairs, our heart rate is going to increase with exercise. The reason being is because we now have more sympathetic nervous system activity occurring within our body. Sympathetic nervous system can be broken down into our accelerator nerve, or we can use hormones. These hormones are going to be epinephrine and norepinephrine, and they're just going to help increase the heart rate. So pretty much like your fight or flight hormones. Once you're trying to fight, you're trying to increase that heart rate. So we're trying to increase the hormones and have that heart rate increase so we can get more blood throughout our body and run away from whoever is trying to kill us. Stroke volume, this is actually going to increase as well with exercise. Reason being is because we are going to have an increase in our blood volume. And then vascular resistance is also going to decrease. Reason why it decreases is because we need to get that blood out of the heart and to the rest of our body. All right. So we know that stroke volume increases, heart rate increases, cardiac output increases, but there's actually a few other things that are fundamental and responsible for the cardiovascular changes that occur during physical activity. So these 4 things, one's going to be mechanical, the second one's going to be metabolic, autonomic, and hormonal. All right, so these 4 mechanisms can increase cardiac output, and they all do it in a very different way, but at the end, our cardiac output is going to increase. So first we have a mechanical change. This mechanical change is actually going to be from our skeletal muscle pump. And what this is going to do is it's going to enhance the venous return So it's going to increase the amount of blood that's going back to our heart. And once it does that, it's going to increase cardiac output because it's using Frank Starling's mechanism. So remember, greater the stretch, greater the squeeze. We're able to fill the heart more, which means we're able to get more blood in and thus getting more blood out, increasing the stroke volume. We know metabolically, whenever we're exercising, there are going to be some waste products that are building up at our working muscles, and we want to try and get rid of those waste products. So one thing that we do is that we are going to dilate the blood vessels in our working muscles, which is going to allow more blood flow to go to our working muscles. So more blood flow gets rid of the waste, and we're able to circulate that to try and increase cardiac output. Because we're getting rid of those waste products, this is going to have more vasodilation occur at the working muscles and vasoconstriction occur at our non-working muscles. Another one is the autonomic response to exercise, and what this happens is we actually have a decrease in our PNS, so parasympathetic nervous system, and an increase in our sympathetic nervous system, which is going to allow an increase in the heart rate, increase in the way the heart can stretch and allow blood to come in. It's also going to increase the contractility, and all of that is going to pretty much be stroke volume, thus increasing cardiac output. So another one that we saw is going to be hormonal. So this is going to be from the sympathetic nervous system, epi and norepinephrine. That epi and norepinephrine is going to be released through the adrenal medulla, and it's going to travel through the bloodstream. Once it reaches the bloodstream, it's going to then go to our heart or other working organs, and these hormones can act upon our alpha and our beta adrenergic receptors to either enhance cardiac function, so increase cardiac output, or it's going to cause vasoconstriction or vasodilation. So vasoconstriction, constricting the blood vessels that don't really need the blood, so where the non-working muscles are, such as our GI tract or things that we just don't necessarily need to have a lot of blood flow going to, and then increasing the blood flow to our working muscles. So, with all that being said, we can now talk about our patient. Now that we know a little bit of how cardiac output and the response to exercise changes. All right, so let's go back to our patient. 56 years old, he had a heart attack. We want to try and exercise him. He's now on diuretics, and he also has an emergency vasodilator. So since he did have a heart attack, there's going to be a few things that we do have to consider before we are exercising him. So I'm just going to go ahead and draw this renal tube for you. And this is kind of how diuretics work, is that they work within this renal area, and what they're trying to do is they are not allowing this sodium to be reabsorbed back into the body. So sodium is then going to stay inside of our renal tube, and if that sodium has stayed in here, that means that they are eventually going to pee it out. And we know that water is going to follow sodium, so more sodium in the renal tube, which means more water is going to follow that, and they're going to be releasing a lot more fluids. What happens here is that the blood volume is actually going to decrease. In low blood volume, this can also result in a decrease in blood pressure. Okay, so with this decrease in blood volume, we're going to also see a possible decrease in blood pressure. So we just need to make sure that we are closely monitoring this patient whenever we're exercising, because they are going to have a lower heart rate and a lower blood pressure than someone who's normally who's healthy and who's not on a diuretic. A reason why they might have an emergency vasodilator is because they did just suffer from a heart attack. So whenever they're going through a heart attack or myocardial infarction, whichever one you want to say, they could also have areas in the heart that no longer work properly. So say we're going to such a really high intensity for our patient, and their heart rate just gets to the point where the exercise demand cannot keep up and properly perfuse the heart. If that's the case, then we may have to use their emergency vasodilator. Reason being is because we want to make sure that our blood vessels can dilate, which can allow more blood to go to the heart and properly perfuse our body. The only problem is, since they are on a diuretic, we need to make sure that we are actively monitoring their blood pressure and that we're only using this in case of an emergency.